I'm Safia Usmani, and this is Fulbright Women Podcast Season 2. We're excited to bring to you 20 brilliant women who are pushing the boundaries in their fields, in their lives, and serving as inspirations to so many around them. Today we have with us Neha Mankani. Neha is a public health practitioner and a midwife. She's the founder of the Mama Baby Fund, a financial emergency fund for maternal and neonatal health. Neha is a Fulbright scholar and holds a master's in public health from Columbia University. She currently works at the Community Health Directorate of the Indus Health Network, where she's setting up and managing midwifery and maternal health programs. In 2021, Neha was awarded a Heroines of Health Award, an award given to 7 women leaders globally who are recognized for their outstanding contributions to health and gender equity. Hi Neha, how are you?
I'm well, how are you?
I'm good. Well, thank you so much for taking out time for this episode. It's been long overdue, actually.
Thank you for doing this, and I'm glad it's you. I know you have a lot of background in these things, so it's always helpful to have someone who really knows how to frame this conversation. I'm excited.
It's good to have conversations, right? I was looking at, I was also just looking at studying about, just researching all the things that you're doing, all the amazing things that you're doing. And I kind of wanted to just start directly from the Mama Baby Fund.
Mm-hmm.
And where did the idea come from? I understand you studied, you did your master's in public health, and you must be, inspired from all your research and academic training and everything. But I still want to understand the story behind Mama Baby Fund.
Okay, so Mama Baby Fund was more a result of, it was less of a planned effort and just something that came out based on what I saw on the ground. So after my master's degree, when I started to do midwifery, I was working at a hospital. I worked at a low-income hospital. The population that this hospital caters to, generally from Karachi, also parts of Sindh, but they're from low-income backgrounds. And what I saw was that I would work in the labor room, I would work in the neonatal ICU, and I saw that there were these really large gaps that people were experiencing in the maternity and newborn care process, where they had planned for something and the costs were much bigger than what they expected, or they just needed to give birth, had a sick child, but didn't have the funds to cover the costs. And it started as something really small. I would talk to people about what I was seeing in the labor room, in the ICUs, about people just taking babies home, or, just having these major emergencies that they couldn't fund. And some people were like, we'd like to help out. So they just gave me a bit of money. It was a very small, friends and family fund. But when I saw the impact that it was having and the kind of the nature of emergencies that people were experiencing, it just kind of organically grew and grew, and it became a registered organization. And we just started plugging in gaps in a lot of different places, and for hospitals for women all over Pakistan. So that's how it started. And, obviously it's evolved a lot in the past 7 years that it's been around, and catering to a lot of different emergencies, and also doing in-kind, filling in-kind gaps that people have. So yeah, that's the history of Mama Baby Fund.
Neha, is healthcare affordable in Pakistan?
So healthcare, I think that's basically the main premise, the main foundation on which Mama Baby Fund has been started, is that healthcare is not affordable. There is a price tag attached to quality healthcare. So there is, the government does provide free healthcare to serve to people, but there's a very large gap in quality. And there's also a very big difference between demand and supply. So for example, if there's a sick child who needs a ICU, newborn who needs an ICU, if they go to a government tertiary level facility, there will be, every morning, there's maybe 5 incubators that will open up. The number of babies that need those 5 incubators are probably around 30 to 40. So whoever is either has good possibility of good outcomes will get to go there, or if you know someone, you can get into an incubator. If you don't have excellent outcomes or you're low on the waiting list, then you might just go home to die. So that's an example of how bad the situation is. So there's quality issues, and if you want to have even subsidized care, is very expensive. So I would not say that there is a public health system at all in Pakistan, and care is not affordable. So, and maternal and neonatal healthcare is something so basic. It's not something that some people need. Everyone needs it, but it's not accessible and it's not affordable, and especially not quality, respectful care that we advocate for. It's not available.
For something so basic, right, when it comes to healthcare and women
Mm-hmm.
in Pakistan, I actually can vouch for that because there have been like a couple of public, government hospitals that I went to, and I
Okay.
saw that the doctors and the nurses perhaps wanted to do much more than what they
Mm-hmm.
were able to do. And it was such a frustrating situation to experience, even as an audience and as someone who cares about, just health, respect, dignity of people. I saw one tiny incubator and it would have, I'm not kidding, I saw four kids.
Multiple babies.
Yes. And they were like, they couldn't even fit in properly, right?
Mm.
And they were made to fit in it because the doctors were just trying their best to give them the care and resources within the limited resources that were available. But
Mm.
it really sparks so many questions about healthcare and the kind of importance, frankly, we give to this issue and women's health in Pakistan, given if we put all the cultural and religious backdrop to it as well, right? How people say childbirth and giving,
Mm.
like, a woman who has more kids is somehow more valuable, from the context of culture and religion, then one would imagine then that these kind of issues would be given more importance, right?
I mean, that's what that's what you would expect. But it's very interesting that you've seen that even that when you like if you go to a government hospital initially, when we do public health work, one of the main things that I learned in uh, um, while I was studying for my master's was that it's always systemic problems. So, it's very easy to say that even when we talk about respectful maternity care, it's very easy to say that doctors and nurses are disrespectful, or, it's because the government doesn't have money or any of that. But it's always a number of things that come together. Like one of my favorite courses that I took was this course called Health Systems Approach to Maternal Mortality, where it would kind of map all of the different factors that contribute to the situation as it is. Um, so even healthcare providers who work in a government setup, even if they really want to be, performing at their optimal level or providing respectful care, the resources that they have are really, really limited. I work at a lot, Mama Baby Fund works at a number of government hospitals around the country, and we'd see things like, administrators they're not able to have staff, so they'll pay like staff salaries out of pocket, or doctors will, mobilize resources in their own networks and they get blankets for the wards, get and cots for the wards, get, just like get the ward clean from their own salaries. And that's not what they need to be doing. They need to have a infrastructure, they need to have a conducive environment to be able to provide the care that they need, right? And that's the same thing we're seeing with midwives, where midwives in Pakistan they are trained to be healthcare providers. They're trained to um, provide maternal and neonatal health services in the community, but they don't have the resources. So they don't have instruments, they're not paid. Um, they don't receive quality training, they don't receive any follow-ups. Like they got a license to become a midwife, but then no one is following up 7 years later that did you refresh your knowledge or anything like that. So because that enabling environment doesn't exist and that no one is investing in that, it really contributes to the negative outcomes that we're seeing, and on something that is so basic and should be considered really important, which is maternal and neonatal care. But I do think that some of it, I mean, I would say that healthcare is difficult across the board, but I think that maternal health is kind of a paradox in the sense that it's so important, like you said, women and babies, but women generally, they're not, it's considered something so basic. It's not considered that women should be treated special during this process. And like, everyone can give birth. It's easy. Everyone has a baby. This woman does not. The kind of importance that we give to women in that process is not really understood, I think.
do you and your community, work on raising awareness and importance of, I'm sure you do, but what are some of the ways that you try to raise this awareness among people that this is something as basic as it is, it requires attention and kind of urgent attention?
So, in when we work on the community level through public health, what the role of the midwife is actually something really big, because midwives are community-based health workers, right? So this is what we've seen in all of our work, wherever we do midwife-led labor rooms, even through my work at Indus and through Mama Baby Fun, is that midwives, because they come from the community, they can connect with the community on a very different level. So it's not just providing a service and then just being done. They communicate with women and their families and their husbands throughout the pregnancy. They speak to them postnatally. They go into the community and advocate for women to be brought in. One of the things that uh, we do, so through my work at Indus, is that Indus Health Network recently opened the country's first boat clinic, which is in South Punjab. It's on the Indus River. It's a clinic that on a boat. So it's reaching people who've never had access to care. But the issue with that is also that these people they don't have that understanding of when to bring someone in or how important it is. So we've seen women who will come onto the boat who are really, really sick because they've just, had a delivery in the community with some guy who's an untrained birth attendant, have really bad infections, might be on the verge of death, but they'll say that, we've never taken our women out of this community, so we won't take them now. It's just not considered important. So a lot of the work we do is through community health workers, where we literally just speak to families and say that, look, these are the danger signs. This is when it's important to bring a woman in, and think about it in terms of a family unit, that if something happens to this woman, what happens to her children? What happens to your livelihoods? What happens to your family? So there are not, the different approaches. I think we never use like those we don't use scare tactics, but we use things that work for people, that, what is the role of the woman in this community? And if she's gone or if her child is sick, what happens to you? So those are just some of the things we look at.
You're also a midwife, right?
Mm-hmm.
What goes into a training of a midwife?
Okay, so the midwifery program in Pakistan is basically, it's designed to be for girls in the community who reach secondary school level, because they want the midwife to come from the community. So once someone has reached secondary school level, they receive a 2-year training, which is basically 60% practical experience, where you'll be in facilities or you'll do home births attached to a trainer, and then 40% is academics. So it's a 2-year program, and at the end of it, when you've done your 10, assisted 10 births, done 10 births independently, observed your 20 births, then you get a license to practice normal obstetrics. So that's what it is. It's basically all over Pakistan, and that's why they're called community midwives, because that's where they come from. The license allows you to practice births and neonatal care and antenatal care in the community or at a facility level. So that's how midwives are trained in Pakistan.
Fascinating. There's now kind of going back to your academic training as a public health practitioner, right?
Mm-hmm.
And it could be untrue in the case of your sector, perhaps, but I want you to reflect on something. There are things that academia teaches us, right? The bookish knowledge, which is great. But then we step into our professional fields and get the experience on ground with, reality. And we realize, oh my God, the things that I studied are not really helping me here, right? And then we develop some more tools to help us navigate that situation. Has that happened in your experience?
So that's happened in my experience, and that has been my experience with my master's degree and my midwifery degree, where I think academics, they make your foundation really strong, but there's so many disconnects between what you study and what you actually see in the field. And I think that's how, with my Fulbright degree, with the master's in public health, I just felt like there were so many public health tools that we learned, and that's why I started really getting interested in maternal health care. That what are the foundations that you need to build in a community to kind of improve the maternal healthcare situation. But when I came back to Pakistan, I just realized that public health in Pakistan is so difficult. So even equipped with all of these tools, there's so many other things that don't make sense. And these were not things that I learned in school. So how do I make this work? And that's where I first started thinking about midwifery, that, it might be useful to have a clinical skill and to be part of the infrastructure in that way. So then in that situation, when I bring my public health expertise with my clinical skills, my impact might be kind of doubled. Um, and that's also what I saw in my midwifery degree, that I was at a school in Karachi where I was trained, and the kind of things so this school, which is really great, they had a really big focus on client-centered care, women-centered care, respectful maternity care. That, the one thing that we always think about is how to treat the women who are under our care. And one of our instructors, she would always tell us this. She said that, I'm telling you this now, but I know that if I come to you in 2 years, you will not be implementing any of these practices because there's so many other things that you'll be looking at. And we'll always go back to her, and she says it's the same thing, right? That when you were in the classroom, you were so gung-ho about, this is how we're going to practice. But when you're in a labor room or you're in a community, when you're faced with emergencies, everything completely changes. So I think it's really interesting how that evolves when you're in real life situations.
There are two things that you mentioned here. One was your academic training in, during your Fulbright experience, right? And the other was the midwifery training in Karachi, right? And I'm pretty sure you deal with women and girls, from all over Pakistan. They're not just from Karachi or big cities, right? So I guess what I'm getting at is the cultural indicators that somehow don't become a part of our academic, knowledge or understanding or training, but once we get into our professional life, we understand there's so many cultural, things that come into play that we have to be very cognizant of. Do you have any such stories where you were on the field and you learned that, these things also play a big role?
Yes, there's so many. I mean, I think until I actually got out and started working with midwives and with pregnant women and families all over Pakistan, I feel like you don't actually know anything because every community has they bring different things to the table, right? So one really simple example of this is that, even at master's level and at midwifery, we do so much and we speak so much about like menstrual hygiene and management. So as part of one thing that we do through Mama Baby Fund is that when women give birth, we give them these care packages. So it has something for the baby, it has like a blanket and clothes and vitamins and things like that. And then we always give women a lot of feminine hygiene products so that when they go home, and even if they want to, share with other people in their home, so they have pads. And I started sending these care packages to one of the labor rooms that I work with through Indus in South Punjab. And I realized, I went back, I sent them started off with maybe 60 care packages. And when I went back a few weeks later, I saw that the care packages were all gone, but the storeroom was filled with 60 packets of pads. And I was like, what's going on here? And they said, look, when women give birth, they take the package, they toss the pads out, and then they leave because the menstrual hygiene in this community is different. Like they've never used pads, and you can't enforce it on someone who doesn't use it, who's never used it, right? You can talk to people about clean ways of operating in their own infrastructure, like how to use cloth safely, how to be clean, and how to prevent infection within whatever you're already doing, but you can't enforce your own ideas of what it works on other people. So these kind of things we see all the time. We see it in neonatal care. Neonatal care is a really big one because how babies are treated is very specific in each community. And I've spent years talking to people about, don't tie babies like this, or don't put this on their face, or don't put this on their body, or don't put this on the cord. And, this is not how you feed a child. But until I understand what the community practices are and how to put my learnings into their community, it doesn't work because no one is interested. And why should they be in listening to something that they've not been practicing?
This is a very interesting thing that you're talking about, actually, because I guess the community, whatever community it is, it needs to feel respected and seen
Mm-hmm.
and acknowledged for its practices in order for them, for the community to adopt anything new that we're bringing to them, right? The menstruation thing that you're talking about, a couple of years ago, I did this documentary, which was just to raise awareness about menstrual hygiene. And the default script that we wrote to begin with was, teaching people to change their menstrual pads, napkins every 4 hours, 5 hours, right? And then I was like, wait a second, why are we assuming that pads are like a norm everywhere, right? So we had to go back to the drawing board and actually come around and create a strategy for them around clothes, right? Because they use pieces of cloths. So how to, just clean them properly, not hang them in, just damp, dark places, hang them in the sunny, areas, all those things, so that they can actually take these things seriously, because then they'll be able to relate with their experiences, right? um, Talking about menstruation and bleeding, there's another thing that, one of the documentaries I was working on a couple of years ago um, taught me. And like, I was exposed to this big bitter reality around postpartum hemorrhage, right? And I didn't know about that. And I realized so many women who die from it, their families and them never really get to find out what really happened, right? They think it's just a regular bleeding or whatever. Can you expand on the threat of postpartum hemorrhage in our parts of the cultures, in countries, and the awareness that is needed for it?
So postpartum hemorrhage is a really big problem, and it's a problem all over the world. But I think specifically in developing countries where we don't have access to quality maternal health care, and the awareness on how to stop it. So it affects it's the number one cause of death in terms of maternal mortality. The couple of things that contribute to main causes of death, which are, high blood pressure in pregnancy, infections, but postpartum hemorrhage is the biggest. And what happens in that is that the couple of things that contribute to it, and one of it is just that after a woman has given birth, her uterus does not contract adequately. And because her uterus does not contract, which we call uterine atony, um, she just bleeds and bleeds until, if she loses enough blood, she's going to die. And a postpartum hemorrhage, it could be for a number of reasons. It could just be a really bad tear that she gets during childbirth, or it's because her blood pressure was too high, so she lost her clotting factor. But it's a really big threat. And I think the biggest thing is that you need to know how to treat it immediately, because someone who's losing blood at that rate does not have a lot of time. So what we do is, especially around women who lose tone, whose uterus don't contract after they give birth, there are very simple ways to work around it. There's syntocinon, which is an injectable uterotonic. There's misoprostol now, which is actually really great because it's it's not temperature sensitive, and you can carry it around. It's just a pill, and if you give it to a woman after she gives birth, her uterus, if she's in a bleeding state, her uterus will contract for the most part. So it's a very simple intervention where you can just talk to midwives about it. You can train doctors on how to deal with it. So in some cases, people have even just spoken to families and said that, if you give birth with a traditional birth attendant at home, keep these pills with you. If you feel like you're bleeding more than you should be, take these pills and they will help you with your postpartum hemorrhage. So it's simple interventions, but I think the main issue is just the training and recognizing danger signs. A lot of times we get women in some facilities where we work, where people dies, or families will bring women in and they'll say that, this woman has been bleeding for the past like 5 hours. By that time, it's already too late. So it's recognizing danger signs when they need to be recognized, so that women can get to a facility at time, keeping in mind that also a lot of these places do have a lot of infrastructure challenges around roads and transportation. And, people come to us from like 5 hours away on a donkey cart. And so you don't always have access to really quick treatment. So there are a lot of delays contributing, and I'm sure you worked on this in your work, is that the number of delays that lead to maternal mortality. So in postpartum hemorrhage, you need to be able to reduce those delays.
Can you talk about the importance of health and nutrition and food intake, that women need, and the connection of that with, the mortality rate of, women.
Yeah, absolutely. So, nutrition in pregnancy is actually very closely related to postpartum hemorrhage as well, because what we see in most of our antenatal clinics in in underserved populations is that women are extremely anemic. So that means that their hemoglobin is quite low. Counseling women on nutrition is also actually very challenging. This is again another thing that's a disconnect. We always talk, especially in midwifery school and in like public health, you always talk about nutritional programs, but I cannot counsel a woman who doesn't have anything to eat that, oh, you should eat meat a few times a week, you should eat fish, you should eat eggs, because I can't say that she doesn't have it, right? So we have to find innovative ways to get people the iron that they need in communities where they do have access to like green leafy vegetables. We do a lot of work around that, about how that can improve the iron stores. We want to bring women in for antenatal care, so we can also give them multivitamins, so that the iron stores are kind of built up during pregnancy, because malnutrition is, which leads to a number of things, but one of the biggest issues when we see anemia is that for a woman who already has a low hemoglobin, if she's already at 8 9, when she gives birth, if she loses blood, she doesn't have a lot of blood to lose. So we'll see women who were already anemic, when they give birth, if they lose blood, they might go into congestive heart failure because they just lost all of the blood in their body. So we really try, nutritional work is something that we really focus on, midwives really focus on during the childbirth process. And that's why we want to get women to us as early as possible, so we can try to work with them so that by the time they give birth, they are in some kind of good health.
This is a very, the nuance here is very important to be understood, that, what you said, that if you know that someone cannot afford and does not have access to good food, you cannot just go ahead and recommend them to be having avocados and, all the stuff, right? That is one nuance. Are there any other cultural, nuances based on either, socioeconomic background, based on where people live, that you've experienced, and that you've come to realize that these are also so many other things that we take for granted, while during our training, and we just kind of use that as a general thing, that okay, we're going to tell this to the patient, they can go ahead and just apply it to their lives, but while really practicing, you've realized there's so many other things to be taken care of.
So there are a lot of things that we think about in terms of, especially in like rural areas where we work. Um, there's things around communication. Things like, I feel like this is something I see in clinics all the time, where we give women prescriptions for medicines and we'd say, this is how you take it, go home and take it. We don't realize that maybe no one in that family can read. No one will, you've written it down, no one can read, no one will remember how to take the medicines. You take medicines wrong, like then they're not working, right? Things like that. Or like, a lot of times we'll say that doctors or midwives will yell at women because they'll miss the antenatal appointments, or they didn't come in on time, or they didn't, they gave birth like at home. But we also really need to start thinking about the kind of ownership that women have over their own bodies. Like, women are not the ones who make decisions about healthcare in their homes at all, not about babies, not about themselves. It's always, mother-in-law, the husband. These are the people who are decision makers around, like the gatekeepers around women's health. So I think those are things that are really important. And what we saw, so we did this pilot when we first started midwifery-led care through the Indus Health Network. We opened this midwife-led labor room. Our pilot project was in this rural village in Rahim Yar Khan called Bhong. And over there was a lot of resistance from everyone. Everyone said, look, women over here are not interested in institutional deliveries. They're not going to come. It's a very controlled area, which is like all the traditional birth attendants are doing deliveries. But I said, look, if we provide quality community-based care, I think they'll definitely come. And we actually saw that, just in the first few months, we started seeing like every month we'd see like 500-600 women in our antenatal clinic, and people were coming to give birth. And I realized it's because they were receiving community-based care, like something as simple as you tell women who come in, they'll say things like, we have all this fancy labor room, and they'll say that I want to give birth on the ground. It's fine. Absolutely. You should absolutely give birth on the ground. Those are very natural ways to give birth, squatting, giving birth on the ground. And if that's what brings them into our facility, then that's the respectful care for them, right? So I think understand those are things that you only understand when you are part of the system and you actually see it kind of play out.
What have been like, if you could talk about your journey so far, some experiences that have just pleasantly surprised you in terms of, it could be anything, whether the woman you were dealing with was very proactive about her health, or the family was very supportive, or, anything of that sort that just pleasantly surprised you.
There are lots of things that have been difficult about the journey, but yeah, there's a lot of things that I've seen which have been really great also. I think something that I find really interesting in working with women at the community level is just how women support other women in the childbirth process, and in bringing them to facilities, that kind of thing. And this is something we see all over the country. So we see it in rural South Punjab. You'll see that if you have to come to give birth, you can leave your children with your neighbor, or some woman who lives in some house like 10 minutes away from you will bring you to the facility. One of the things that I do right now is I do antenatal clinic at this island. It's called Baba Island. It's in the middle of the Arabian Sea in Karachi. And those women at the island, they don't have access to any healthcare facilities. They come to my antenatal clinic once a week, and then Mama Baby Fund supports them to give birth in Karachi. But that means that when they go to give birth or they go to get an ultrasound, they have to get in a boat. They have to find a boat. They have to get to the port, to the land, and they have to get a rickshaw, go to the community. And in that, the only reason they're able to do it is because they have support from other women, that you can't get in a boat and go by yourself, but can you ask your neighbor if she can come with you? Or can you ask your sister if she can come with you? So we hear so many stories of women uplifting other women in the community, especially in this process. And that if my baby's sick, I took money from my, this woman that I worked with, and she helped me through this process. And it's really nice to see how people come together in that thing. So that's just one thing that I think has been great for us to see.
Yeah, that's beautiful. The collective feeling of sisterhood, right? Of just being there and being a support system for each other. Well, that brings me to the award that you recently got, the Heroines of Health Award. Congratulations for that.
Thank you.
Did you always aspire to get, awards like the Heroines of Health Award? Do you consider it a milestone, personal milestone? I just want you to talk about that, if you consider it a personal milestone and what it means for you.
So I wouldn't say that I've aspired to get any awards, but because I think that, the work that I'm doing is because I'm doing it. You don't have to have that kind of, you don't have to be validated for your work. But what I think is, I consider it a personal milestone because I think it's really great that people are talking about why, the reason that I got this award was because of the main things that I think were highlighted was my work around respectful maternity care and my work around health equity. And why am I doing this work around health equity is because there's a need for work around health equity in Pakistan, right? So I think just to even get those conversations started, that someone won an award because they're doing work around health equity and getting maternal health care to women who don't have it is a really big thing. So I think in that way, I do consider it a personal milestone, that to get to that point where people are recognizing that these gaps are so big that someone who's doing it should be awarded for it. So I think it's been great. And I think it was a really big honor for me. The other heroines of health are people who've just done some really, really wonderful work in health around the world. So it's really great to be celebrated with people like that.
Of course, congratulations. And like you said, the bigger goal is to get the cause, talked about so that more awareness could be, created around that. In terms of health equity, we've talked a lot about it already, but I guess to just wrap up the conversation, if I ask you, what are some of the next immediate steps that you would, encourage the community at large to adopt in terms of health equity, what would they be?
I think when I talk about health equity, there's just so many things. One thing, when I talk about Mama Baby Fund, I always feel like people should kind of, find ways to support people in their own community. And this is something that we've seen, that we've learned from, like, again, the whole sisterhood concept, that we'll see women in facilities who will just, who don't have any resources, will find a way to help someone who is on the next bed as them. And I think that concept, it starts from a micro level, goes to a macro level, where because we don't have a health safety net in Pakistan, we need to find ways to provide that safety net to other people. So I think I always encourage midwives. I always meet midwives who'll ask me that, how can I contribute to Mama Baby Fund? And I said, I don't think that you should, but I think that you work at a health facility. And if you feel like someone needs support of any kind, then you find what that support is and how you can provide it. So, finding ways to like kind of be a health champion in your own community. And the other thing around health equity I think is just, which I think is such an uphill task, but what we're trying to do is just kind of getting, elevating the status of midwives in Pakistan, because I think if you, like a lot of work we do around Mama Baby Fund, and a lot of work that I've been able to do through the Indus Health Network is just, equipping midwives with the tools and the resources and the training they need to be able to become health champions in their community. And I think a midwife is just such a useful health resource that if we have qualified midwives in communities, we've already seen through the 3 labor rooms that we run through Indus and the 4 antenatal clinics, we've seen them transform like maternal health indicators of entire communities, like just a team of 4 midwives. So I think that advocacy just really needs to kind of be increased so that we can get, because that healthcare worker can get a lot of things to community in terms of maternal and neonatal healthcare.
I'm curious, how is a dai different from a midwife? And do you find resistance from the dai community perhaps towards midwifery? Or do you think they can also be, somehow included in the whole program of midwifery because they're also coming from the community, right? So I want you to expand on that a bit.
So it's very, our relationship with dai is actually very, very complicated. So a dai is a traditional birth attendant. She has received no academic training, doesn't have a license to practice or any of that, but has a lot of like, community experience. They've just been delivering in the community, a lot of times older women, and midwives are trained birth attendants. So that's the main difference. It's very complicated because in Urdu, there's no word for midwife. So automatically it gets translated to dai, but midwives are very offended when anyone calls them a dai. There is a lot of resistance, and I think the difference is, and this is where I think the community midwifery program went wrong a little bit in Pakistan, is that community midwives are actually very young. Because when you take a secondary school girl and you train her for 2 years, by the time she's done, she's still just in her 20s, So to be able to have that kind of community access, midwives can't move around in communities the way that dais can, no, she can't wake up at 3 o'clock in the morning and walk to someone's house like 40 minutes away to give birth. Like, it's difficult. So they don't have that kind of mobility. They don't have that kind of control over the community. Like when someone who's been delivering for 15 years, if someone new comes in and say, I have more skills than you, no one is going to take her seriously, So there is a lot of resistance from dais, and there's resistance from families. And there is a lot, it's very hard for midwives to kind of find their way in this system. We do work with dais. I think the general understanding is that you have to work with dais in a very specific way. Like, we can't equip them with any resources because we want there to be a shift towards community midwifery. But we do work with them, like, Abhi, right now, I'm planning in the next 2 weeks a session with the dais in one of the communities I work in, where I'll call them all in. And, we give them neonatal resuscitators, that if you were to deliver a baby and you see a baby in distress, this is how you can resuscitate the baby. Or if you see a woman bleeding, this is what you should do. These are the danger signs. If you see these 10 things, please send a woman to us. So we can't stop a dai from operating, but we want them to be safe in the parameters that they work in. Because some of these things this is just one anecdote I want to share, because this is something I'm really working on these days. It's kind of driving me crazy, is that that oxytocin, when you talk about postpartum hemorrhage, oxytocin is the main drug that is used as a uterotonic. What I saw a few months ago, I was in a rural community, and I realized that what was happening was that dais were using oxytocin to speed up labor, But what they were doing is they're using veterinary oxytocin. So they're using oxytocin that is actually for cows and goats and things like that. And it's very strong. But they realized that, oh, if you can use oxytocin, you can give it to a woman when she's in labor and it makes her deliver in like the next 5 minutes. But it also might make her uterus rupture and might kill her. So, all they learned from this was that oxytocin is a useful drug. But then they realized that, oh, I can do so many more things with it. So I've been on this like hunt to figure out how we can regulate oxytocin so that cow oxytocin stops going to women and killing them. So these kind of
Yes,
things
please.
are
Yes,
these things
please.
are kind of things are really complicated. And when you work with traditional birth attendants, you have to be really careful on how you do it to make sure that they're not using drugs wrong or in for the wrong things. So yes, the long and short of it is that yes, dyes exist. They are very difficult to deal with, but yes, we have to find ways to work with them.
Well, Neha, I'm so sure that in these 45 minutes that we've been talking, um, we have hardly touched the tip of the iceberg, and there's so many challenges, and there are going to be so many hardships that you get to experience and your community gets to experience on a daily level. But I am also sure that you think it's all worth it because of the kind of impact that it's creating and potentially can create even in the future. So I guess I'm just going to say thank you so much for all that you're doing, and keep at it. And thank you so much for taking out the time to talk to me today.
Thank you for having me. It was really great to share a bit of my story. Thank you.
Of course. You have a great day ahead. Thank you, Neha.
Thank you, you too.
Bye-bye.